Welcome to this evening's webinar. You've got myself, James Thing, sport and exercise medicine consultant, and Natasha Beach. We're going to be doing an hour, probably 40 minutes each, and then some questions on some of the common musculoskeletal injuries that we see in primary care. So thanks for joining us. There is a question and answer tab either at the bottom or the top of your screen. If you've got any questions for us, please write them down and we'll check them out at the end. And the other thing to note is that this session will be recorded and shared on social media, which should be available at the end of the week. So just a quick bit about my background. So I'm a sport and exercise medicine consultant. I trained as a GP before going into sports medicine training, and I've been a consultant in London now for about 6 years, and I've recently started at Welbeck. My background in elite sport is that I work for Harlequins Rugby and also British Athletics, and I'm going to be talking tonight on bone stress injuries and calf injuries, so two ends of the spectrum there. So we will get hopefully straight into it. Here we go. So bone stress injuries. So I see bone stress injuries in my sports medicine clinics very, very frequently. We see them in general practice as well, fairly often. And it's not just the super endurance athletes who we can expect to see. I've, in recent months, actually seen a lot of individuals who've done training such as Joe Wick's training, high intensity training, and even going from couch to 5K. So it's something we've got to look out for in everyone. Common injury, we see it obviously far more commonly in the lower limb and to a lesser extent in the spine and pelvis. And then obviously upper limb injuries are far less common. Within the lower limb, we tend to see it more in the metatarsals, some of the mid-foot bones. Followed by the shin, so the tibia and the fibula is another common site of bone stress, and then as we mentioned, far less commonly in the back and pelvis. So the classic athlete or the classic patient tends to be an endurance athlete or track and field, and as I say, it doesn't necessarily have to be a super athlete. We certainly see it in the normal population, certainly in the deconditioned population as well. And it tends to affect females far more commonly than males, and we'll talk about why in a minute. So the ultimate crux of the situation is that what we're seeing is cyclical repetitive overload of the bone, and that is what's causing the main problem. And this is a graph or drawing that I tend to draw for most of the patients with a stress fracture or stress reaction. And what I tend to say is that bone exists on a continuum. So at one end of the spectrum, we've got completely normal bone. At the other end, we've got a fracture. And as we go along, as we increase the load, we go from normal bone to stress reaction, to stress fracture, to fracture. And the more load we put through bone, the more we're going to be heading towards the fracture side. And the way that we treat any bone stress injury is by reducing load, taking the stress off the bone and moving more down towards the side of normal bone. And ultimately, that's the way that we would assess and manage any sort of bone stress injury. So what are we looking for specifically? Generally with bone stress injuries, we're looking for very focal, specific and localized tenderness. And obviously that's mainly bony tenderness. So for superficial bones, such as a metatarsal, it's usually a fairly easy diagnosis to make based on history alone. Generally, patients will complain of this nasty gnawing, aching discomfort, which can wake them from sleep at night, which is one of the classic questions that we tend to ask. If they haven't got nocturnal symptoms, doesn't necessarily exclude it, of course. It tends to be worse with weight-bearing activities. So what we'll tend to see is someone will describe pain that tends to come on after running. As they push through and they push on and continue to train, it may be that they start to get pain slightly earlier in the runs. And it may get to a point where they just can't run because of the severity of pain. And that's that crescendo type pain that we expect to see. It's always important, I feel, to ask about training. And we specifically ask about the fit criteria. So have they changed the frequency, so the number of training sessions per week, the intensity, the overall time, or the type of training? So have they gone from training on grass or sand to a harder surface such as roads, which is going to potentially precipitate an increase in load? We're also going to ask about footwear. Basically, the crux of it is what has changed in their training, in their day-to-day activity, which could have brought on a bone stress injury. Very important to look at diet, and with diet comes things like eating disorders and energy availability. And that's not just now, but it's also, have they ever had times in the past when they've had issues with energy availability, low body weight, or eating disorders. Very, very important. It's also important in the female population to ask about periods. So do they have frequent regular periods? Have they ever had times when they've had no periods, episodes of amenorrhea? And are they on the combined contraceptive pill? Because often you will ask an individual, how are your periods? They'll say absolutely regular, every 28 days, no problems. Next question, are you on any regular medication? Yes, I'm on the combined pill. And of course, the combined pill is going to give you an artificial regularity to your period. So it's important to ask about whether they've had problems before they were on the pill. Have they had bone stress or stress fractures in the past? That's another important question, and obviously a risk factor for developing future bone stress. And lastly, we're going to be asking about the BMI. So it's important to determine if an individual has a particularly low BMI, because that potentially puts them at risk of certain syndromes such as the female athlete triad, which we'll go on to talk about a little bit more in a second. So on examination, we're looking for bony tenderness, we're looking for bogginess, swelling. And again, classically, if we're looking at the metatarsals, what we would expect to see is loss of definition of the extensor tendons within the dorsal aspect of the foot. And in the shin, we often actually get pitting edema. And both of those criteria would raise suspicion of bone stress, in particular stress fracture. Dynamically, we can get them standing, single leg balance, we can get them hopping. And if they've got pain on hopping, again, with localized bony tenderness, that's fairly indicative of a bone stress injury. Obviously, within a 10-minute consultation, I certainly don't expect you to have a look at the biomechanics in detail, but it's something that we certainly need to consider. Lastly, I'm very lucky. I've got ultrasound machines in all of my clinic rooms. And what I will tend to look at is, particularly with the superficial bones, so the metatarsals with the tibia, is there a little area of bony irregularity, cortical irregularity overlying the area of maximal tenderness? Is there some associated vascularity or increased blood flow along the periosteum? And is there subcutaneous edema? All of which is going to make me slightly more suspicious that there is a bone stress injury. The ultrasound in itself won't be definitive. So MRI tends to be the gold standard. And what are we looking for? So on a T2 weighted sequence, we're looking for bone bruising. And you can see in this image here, we've got some bone marrow edema or bone bruising within the medial cuneiform, which is highly suggestive that the bone is being overloaded, but isn't entirely specific for a stress fracture. Having confirmed bone stress or a stress fracture, I would then consider some blood tests. And we're looking specifically at things like bone profile, liver function, and hormone profile. And again, if we find a stress fracture, particularly in a young female individual who has low BMI or relative energy deficiency, then I would certainly consider getting a DEXA scan, looking specifically for osteopenia and osteoporosis, which will then determine how we treat the injury in the long run. Ultimately, the mainstay of management to stress fractures, stress reactions is pretty simple. It's about offloading. And that offloading is obviously relative. So if we have an individual who's training 120 miles a week, relative offloading for them may be reducing down to 20 miles a week. If we've got an individual who's relatively deconditioned and who has 8 out of 10 pain just walking to the shops, then clearly we're going to need to offload further. And that may involve something like an air cast boot, plus or minus crutches as required. Of all the injuries that I tend to see in musculoskeletal and sports medicine, I would say this is the one where they tend to benefit the most from a multidisciplinary team approach. Usually after a short period of offloading, when we're starting to see symptomatic relief and they're starting to get back to walking more comfortably, that's at the stage when I tend to involve a physiotherapist. Obviously, if they're in an air cast boot, the ankle's going to get stiff, and we'd certainly recommend seeing a physiotherapist so that we can start to work on the stiffness within the ankle and optimize that side of things. Also, obviously, a physio or an osteopath rehab specialist is going to be particularly important for that return to play guidance. And also looking at any biomechanical abnormalities and trying to assess what is it that is predisposed to them developing this injury. Alongside that lines, I would also consider getting involvement of an expert podiatrist who can look at the foot from a static point of view, but also biomechanically when moving on a treadmill. This is going to be essential for ensuring that we prevent future injuries once they've returned back to activity. Lastly, if someone has an issue with energy availability, eating disorders, or even addiction to exercise, which we do commonly see. Indeed, I had a patient recently who had told me that they'd run every day for the last 7 weeks. And clearly that's not normal. It's not normal in an elite population. And that's something that needs to be taken seriously. So when needed, we'd certainly involve a dietitian and psychologist. I wanted to touch very briefly on something called the female athlete triad, or relative energy deficiency in sport. Basically, this is a triad which starts with low energy availability. And the sort of individual who I would normally discuss with a patient as using as an example would be an ultra endurance athlete, female athlete, who is expending far more calories than they're taking in, and therefore have a state of low energy availability. And that can be with or without an eating disorder. That can then lead on to functional hypothalamic amenorrhea, which basically means that if we're not getting enough calories in, we're going to be shutting down all non-essential functions, which includes periods and fertility. That can then also have a direct impact on bone health and can lead to osteopenia and osteoporosis. Now we can see at the other end of the spectrum, if we can manage to normalize that energy availability, then we get them back to normal energy availability, normal periods, and optimize their bone health. And I just wanted to touch on this very briefly, is that generally, if we can reverse that energy deficiency state, then things tend to recover quite quickly so far as energy status and menstrual status. The thing that takes much, much longer is a return to normal bone density, which can take up to years. And that's why it's so important to ask the question, have they ever had times when they've had no periods or low BMI or any form of eating disorder? So to summarize, we see bone stress injuries very frequently, particularly in the athletic population. It's very important to diagnose early to ensure that they're not pushing on and pushing from that bone stress to stress fracture to fracture. And the key is to offload early. We would certainly consider further investigation, including blood tests, bone density, particularly if they have a low BMI. And the key is going to be a gradual progressive return to activity once symptoms and pain is settling. It's also very important to consider mechanics, and it's important to have a thorough look at the mechanics in order to return them back to sport safely and to prevent further recurrence. So obviously we'll have some questions hopefully on bone stress injuries in a second. I'm going to move on to my second topic, which is calf injuries, which is almost the opposite end of the spectrum. So again, calf injuries, really, really common injury that we tend to see in a sports clinic. Also very, very common in the general population. It tends to be seen not so much in the endurance sports, but more commonly in the sprinting and team sports. The classic description is of a tennis leg, which is, strictly speaking, a tear of the medial head of gastrocnemius at the muscle tendon junction. If you exclude the elite literature, generally speaking, the medial head of gastrocnemius is the more common location for a calf injury, followed by soleus, the deeper muscle, and then the long head of gastrocnemius. The gastrocnemius is thought to be more common as it crosses both the knee and the ankle joint, putting it at slight neuromuscular disadvantage compared to the soleus. The other important thing to consider is making sure that we are being specific and differentiating between a calf and an Achilles injury, which can sometimes be quite difficult without imaging. So just having a look at the anatomy briefly. So that, as we said, the soleus is the deeper of the two muscles. It's generally used for endurance and for walking. It crosses just the one joint, the ankle joint, and the gastrocnemius is more for that sprinting, jumping type maneuvers, as it has a much higher proportion of type 2 fast twitch muscle fibers. So what are we looking for? So the classic description is of that sudden popping or snapping sensation, usually or often during sport, but not always. And it's classically, the classic description is in middle-aged, potentially overweight male who's on the baseline of the tennis court, and there's a drop shot and they sprint for the drop shot and they suddenly feel as if they've been shot or kicked in the back of the leg. Often they'll have difficulty initially weight bearing, and we may well see some bruising and swelling associated with that. Generally, when we're assessing them, we're going to get them, we're trying to perform a single leg balance. If they can do that comfortably, then we're going to see what they can do with single leg heel raise. And if they can do that, we'll push them on and see if they can hop. And obviously, if an individual can hop without pain, then that's pretty reassuring generally. We're looking for swelling, and generally with these sort of injuries, there is point localized tenderness. And what I would tend to do is mark that very specific localized area of tenderness so that we can then have a look with the ultrasound. What we're generally going to experience is pain on resisted plantar flexion and pain when we're forcing them into dorsiflexion, so stretching the calf complex. The other important thing on examination is to get them into a prone position, so lying flat, face down on the couch with their feet hanging over the bed. This is a really nice position to be able to assess the integrity of the muscle tendon unit. And generally, if they've ruptured the Achilles, they will lose the normal plantar flexion tone. So in someone who has an intact calf Achilles muscle tendon unit, we'll be able to see the forefoot when we're looking down in a prone position. In someone who's lost that complex, who's ruptured their Achilles, for example, we will lose that plantar flexion tone, and you won't be able to see the forefoot when they're lying with their feet hanging over the bed in a prone position. The other thing that we have, the other test that we have is a Thompson test, which is a squeeze test where we squeeze the calf and we're looking for passive plantar flexion with an intact Achilles complex. So this is generally what we're looking for with ultrasound. So ultrasound is a wonderful way of assessing calf injuries generally, and allows us a very, very good view and allows us to really drill down, looking closely at the gastrocnemius, which is the superficial muscle that we see here in red. It allows us to look at the muscle tendon junction, which in an intact calf, so this is comparing an intact normal calf to a symptomatic calf, you can see here that the medial head of gastrocnemius comes right up to the muscle tendon junction, with the soleus, the superficial border of the soleus, very clearly seen. In the injured side here, you can see that the medial head of gastrocnemius has retracted from its normal position at the muscle tendon junction, and we can also see a fair amount of fluid in the interfascial interface between the superficial soleus and the medial head of gastrocnemius. So ultrasound, very, very useful in this circumstance, and also tells us a lot about the Achilles, so we can go on to really have a close look at the Achilles. In someone who walks in with a lot of pain, with functional disability, with a completely normal ultrasound, the likelihood is that I will consider an MRI, because the vast proportion of soleus injuries can be missed with ultrasound, as it's a deeper muscle, and therefore an MRI is much more likely to pick up these subtle injuries. So how do we manage these? Well, generally speaking, obviously the vast majority of patients who sustain a calf injury or a minor calf tear will manage this very successfully at home on their own. If we do get access to the patients, then for example, in a rugby environment, if I've got a player who's just come off with a calf injury, what we'll do initially, having done an assessment, is try to protect the calf. So we'll put them in an air cast boot probably over the weekend just to offload. From there, we're going to start to optimally load. So start to reintroduce light walking and exercise as pain allows. And in the initial stages, we're going to be icing, compressing, and elevating. The one caveat to this rule, where most of these are successfully treated very conservatively and settle very well on their own, the one caveat to that is the individuals who we see fairly frequently, where the individual has sustained quite a massive injury to their calf, and they get a massive, tense, swollen, tight calf, which is very, very painful and functionally very debilitating. And it's in these individuals who I would suggest that we try to get access to them very quickly, i.e. within the first week or 10 days. The reason being that if they have a tear like the one that we've seen on the previous slide, where there is a large volume of fluid seen in the interface between the gastrocnemius and soleus, then we would argue that it's worth seeing them quickly and considering aspirating. And in these individuals, we can get up to 100 to 200 mils of serosanguinous fluid that we can aspirate. And you can imagine the relief in someone who's got a very painful, tight, swollen calf. That is particularly useful and gives them immediate symptomatic relief. From there, we would then consider compressing the calf using something like Coban, and then booting to offload further. I would then review the individual at a week and consider reaspirating. Often there has been some accumulation of fluid, and we would consider reaspirating. And the reason we do this is that otherwise we get this sort of result. So this is an ultrasound of an individual who's had a massive calf injury. And again, it's the medial head of gastrocnemius here, which has sustained an injury at the muscle tendon junction. So there's been significant retraction of that muscle tendon junction in the medial head of gastroc. And we're seeing this massive volume of fluid, or what was fluid, that was sitting between the deep part of the medial head of gastrocnemius and the superficial border of the soleus. And you can see that this measures 18 centimeters in craniocaudal dimension. So it's a huge, huge injury. The problem is that this individual was seen about 4 to 6 weeks down the line from the injury. And what we can see is that this is no longer anechoic, it's no longer black. there are areas of heterogeneous change, and that indicates that the serous sanguineous fluid has started to consolidate and scar up. And actually, if we were trying to compress this with the probe, we would see that this is not amenable to compression, and we certainly wouldn't dream of trying to aspirate this because we wouldn't get anything. But had we seen this individual 4 to 6 weeks earlier, then potentially that would have been amenable to aspiration. This is an individual, so this is a video showing what it looks like. You can see the anechoic fluid between the gastrocnemius and soleus. This is a little fascial band in here. And this is an injury which would potentially be amenable to aspiration, although the volume of fluid there probably isn't quite so significant. So initially we protect, optimally load, ice, compress, elevate. From there, I would always consider getting the opinion and advice of a specialist physiotherapist. We're looking to optimize range of movement, start to work on calf strengthening and balance. From there, we'd progress on to a run-walk program. And then as we get further along in the rehab program, we're starting to introduce sport-specific drills and then a graduated return to full activity. Now, we do get these individuals who have these recurrent, repeated injuries of the calf following an injury such as this. And it's worth looking statically at mechanics. So is there something going on within the knee, within the ankle? Have they got a restriction of range of movement? Have they had a previous ankle injury, which is predisposing them to getting recurrent calf injuries? It's also worth having a word with their coach if you have time, their coach or strength and conditioning input, the physiotherapist to look and see what is their sprinting technique like. With that previous injury that we saw, where there was the unzipping of the medial gastrocnemius from the soleus and that massive volume of fluid, which then scars up, we can get adhesions forming between the soleus and gastrocnemius. And you can imagine normally those two layers slide very nicely, one on top of the other. If we've got scarring between the two and adhesions forming, what can happen is that you get recurrent micro tears of that scarred tissue, and that can mimic a calf, an intrasubstance calf tear. The one thing I would say is that those injuries tend to recover very quickly. So they develop a tear-like sensation, which settles within a week or so before returning to activity. But these can be quite tricky to treat and to return back to full activity. And the last thing to look at is the lumbar spine. So in individuals who have recurrent calf tears, but normal appearance of their calves, it's well worth considering imaging of the lumbar spine to see if they've got radicular signs and potential compression of a nerve root, which is leading to issues with neuromuscular firing. So to summarize, calf injuries are common. Often they require very little input. If there are those episodes of a very large, tense, swollen calf, then I would consider offloading quite aggressively and potentially considering early imaging as available. Generally, ultrasound will pick up most gastrocnemius injuries, but will probably miss the vast majority of soleus injuries, in which case we'd consider MRI imaging. If they are recovering slowly, if they're not following that normal expected course over 2, 4, 6 weeks, then it's certainly worth getting the input of a specialist physiotherapist, osteopath, rehab specialist for specific input. And as we said, it's worth looking closely at the mechanics and at the lumbar spine if we're getting these recurrent unexplained calf injuries. So that's that. We will take questions on the bone stress injuries and calf injuries at the end of the presentation. I'm going to now hopefully hand you over to Natasha, who's going to be talking about concussion and non-red flag cases. Thanks.
Hi everyone, I hope you can now hear me. Thank you for joining me. Just to explain my slightly odd background, I'm currently in a spa as I am covering a tennis tournament, and this is the best place for Wi-Fi, so I do apologise for the slightly odd background. As James explained, I am going to talk to you about what I'm calling non-red flag cases, i.e. a number of cases where the classic red flags were absent, but the pathology was relatively interesting. And then totally unconnected, I'll then go on to talk about some concussion. So if I can get this to work. As James also explained, I'm a sports medicine doc, and it's also based at Welbeck. In addition to that, I also do paediatric clinics twice a week. And then I also work with James, because he can't get rid of me, at Harlequins and British Athletics. And I also cover a little bit of England hockey and England athletics. And then, because I haven't got enough to do in my life, I also work at some major sports events. both in an advisory role and as their medical director. So I'm going to kick off first with case one. So this was a gentleman that I saw only 3 weeks into my consultant role. He was a 34-year-old gentleman of Afro-Caribbean descent who came into my clinic in the city. He was already slightly unusual in his appearance compared to the typical city workers. For a start, he had purple contact lenses in, which were a little bit distracting. And his main presentation was essentially that he had a 1-month history of lower back pain. Delving into that history a little bit more, it was of an insidious onset and was a relatively low grade. At worst, it was around 3 out of 10. Actually, when I saw him, things were already starting to improve. The pain was central around L3, L4, and the symptoms were very specifically there. There was no radiation down into the legs, and he had no bladder or bowel changes. He tried a few days of anti-inflammatories, and that seemed to be working. And he described it as a kind of an achy pain. Looking more in the history, he had had some night pain, but that was around 2 weeks earlier and had settled. It had lasted only for 3 nights. No previous back pain, and this despite him being quite a tall gentleman and being desk-based for most of his work. He didn't do any physical activity other than walking from the tube to work, but was fit and well and wasn't taking any normal regular medication. So we went on to examine him, and he actually was pretty good. In full flexion, he could bend over, he could touch his feet with no pain whatsoever. He was, however, sore on extension, particularly again around that L4, L5 region, and he had a positive stalk test. He was definitely on the hypermobile end of the spectrum with a Bateman score of 6 out of 9. And the rest of the examination wasn't hugely remarkable. He had normal sensation, normal tone, normal power within his legs, but single leg squats were pretty ropey. He was pretty wobbly with poor knee and hip control on both sides. And then lastly, palpating his lower back, we could see that he was sore over L4. So my initial thoughts were, given he's got pain on extension, is this something that's facet joint related? I also was very conscious he was hypermobile and had this little bit of night pain. So I thought, well, is there also either a bony stress response or a stress fracture that was brewing? And also because he was so mobile and so tall, I also wondered whether Marfan's might be something that was going on in the background. Essentially, I felt that something wasn't quite right, but I couldn't put my finger on it. So we went on to form the following plan. So we arranged an MRI scan. We talked about analgesia, and actually as he thought that things were improving, we decided that he didn't want any analgesia at the moment. And then we were going to review him with the results of his MRI scan. So what happened next? Classic phone call, 5 o'clock, Friday evening, phone call from the radiologist. The MRI had essentially shown that he had compression fractures at both L3 and L4. The L3 in particular was incredibly unstable, and the words of the radiologist was on the verge of collapse. And unfortunately, he also had metastases noted from T11 down to S1. Now, this obviously was not something I was expecting, something the patient wasn't expecting. So what I did was I phoned the patient that evening and gave them a little bit of background. I didn't obviously break the full bad news, excuse me, but I did kind of give them the warning shot that there was something on the scan and that we needed to see him a little bit sooner. Excuse me, I'm getting a cough. I then, in the meantime, phoned their GP to make them aware of the diagnosis and was telling the GP when I was going to be breaking the news to the patient. I also found a friendly surgeon who specialised in bone cancer of the spine, and we planned to book him in within a few hours of seeing me on that Monday morning. And then I changed my diary, so I blocked out a couple of hours so that actually I could give the patient the time that he needed to break that news, because obviously there was no prior warning shot I could give because this was all a little bit of a surprise. So that patient went off to oncology, and that's kind of the last that I saw of him. But it made me really think about the red flags and whether there was anything in his story that would make me think that actually there was a red flag there. And looking through this list, actually none of that cropped up. His pain wasn't thoracic. He wasn't particularly young. He wasn't particularly old. His bladder and bowels were fine. There was no leg or arm weakness. There was no neurology within the legs. And then he'd had no high fever, no previous cancer, and no obvious structural deformity. So that was a little bit of a shock, not something that we were expecting, but he went off and he got the treatment that he needed. Lo and behold, 6 months later, we have a second case. So this time it's a 50-year-old lady who is predominantly desk-based for work. She was actually already under the physios in the clinic for having lateral ankle pain, which was improving and doing well. On the 4th session of her physio, however, she mentioned that her lower back was starting to feel a little bit grumbly. And this physio in particular is particularly keen on treating backs, and so diverted the treatment temporarily to focus on her back. Unfortunately, she wasn't kind of getting better, and there was a little bit of a concern that something wasn't quite right, and the physio couldn't put her finger on it, but we knew something didn't quite match. So then she was referred to me and I saw her. So the back pain was flexion related. There was no trauma, no night pain, no limb symptoms or bladder or bowel changes, but the pain relief that she was taking wasn't helping. And also the physio input that she'd been having was also not helping. And so that gut feeling again came back of something's not right here, something isn't adding up. In terms of her other history, she just had some hypertension. She takes the amlodipine for her high blood pressure, and the paracetamol was what she was taking for her back pain. Unfortunately, she couldn't take ibuprofen because she'd had a prior history of a gastric ulcer. Examination-wise, showed that she was actually quite limited in flexion during her pain. She probably could reach about 20 to 30 degrees. Extension was pain-free, and the rest of her neurology was fine. We then looked at her hips and found that she had a full range of movement, no pain. And actually palpating the lumbar spine was unremarkable again, but the musculature of her back was particularly tender. So from a plan perspective, we looked at her analgesia and added in some low-dose codeine, and then planned for her to have the MRI and come back to see me for the results. The plan was also to continue physio during the meantime. So what happened next? Another phone call, 5 o'clock on a Friday night from a radiologist. This time, the scan had shown a metastasis within L3, or so they thought, but they weren't sure whether this could have been a primary or whether this was actually a metastasis. So I went through a very similar process as done with the previous patient, brought the lady's appointment forward, phoned the GP to make sure they were aware, booked that urgent surgical review so that everything was already in the process, blocked out my diary. And for that, because of the rapport that the physio had with the patient, we also brought the physio into the consultation just to help with the breaking bad news. And that was really important because they had a really close bond between them, and it just helped lessen the blow and also gave the opportunity for her to ask more questions. And then the last case I want to present is a patient that I saw in my school clinic. So it's a 15-year-old child that I actually knew pretty well. He's had a previously challenging concussion where he was off sport for 6 months and actually off school for around 2 months of that period. I'd actually finished my clinic and the nurse knocked on my door and said, oh, this kid has come down and is in quite a lot of pain. Would I mind seeing him at the end? I said, yeah, absolutely, come on in. And he basically had 24 hours of neck pain and burning in the region of C5, C6 within his right arm. On further questioning, he'd had 2 prior episodes of this. The first one was 4 months earlier, where he'd been seen in A&E, discharged, told it was all musculoskeletal, will settle, and his symptoms settled. Within 5 days, they'd gone. 2 months later, very similar episode, this time didn't seek help, and again, it resolved in 5 days. So in terms of his past medical history, I already knew about his concussion, but I also had access to his GP notes. And looking through those notes, I could see he'd recently had a lower respiratory tract infection where he'd had a bit of a cough, bit of a fever, sore throat, some raised lymph nodes. And that was around 1 month ago. And the GP had seen them, given some antibiotics, and he'd got better. Everything had settled, and he now felt completely well. So what was unusual about him is when he presents, he'd said that he had a lump around his clavicle. And this lump would come up every time that he had his neck pain and then would go away again. And so he mentioned to me that this lump had come back again that morning. So on examination, you could see that he had this very obvious lump here. Looking at the neck itself, he had flexion would aggravate his arm symptoms. The left arm was totally fine. he had altered sensation within the right arm, and then on actually palpating this lump, recreated the arm pain that he was getting. So again, I got that feeling that this isn't just a simple nerve entrapment within the neck. Something else is going on here. So I arranged an urgent MRI of his neck and his upper chest because I wanted specifically to catch this lump area. And so what happened next? Phone call from the radiologist. So the MRI report showed that he had a normal C-spine, but unfortunately the chest showed widespread lymph nodes, which was pressing on the brachial plexus, which then explains why that palpating of that lump was recreating his arm symptoms. Now, because I'm only down at that school 2 days a week, what the school did was to contact the school GP, who then brought mum and the child in for an urgent consultation. He was then admitted under the NHS in Guildford, and the biopsy showed that he had non-Hodgkin's lymphoma. So he then went on to have radiotherapy, 5 sessions of chemotherapy, and he's actually one of the cases that I'm actually able to follow up because he's still a pupil at the school and is currently doing really well. So my take-home messages are from kind of these cases are, while MSK cancer is rare, it is out there. And while we've got this list of red flags, actually all the 3 cases that I've seen since being a consultant, they didn't really tick any of those red flag type boxes. I think my general feeling is if something isn't improving, you've got to ask why. And if you've got a gut feeling, follow your gut and investigate it. If something just doesn't feel quite right, follow that reasoning and try and work out what's going on. And then if you are concerned, then you should be referring and getting scans and getting second opinions just so that we can work out what's going on. So, completely separate discussion. Now I'm going to go on to concussion, because as sports doctors, we don't just see MSK. James and I particularly both work in rugby, so we see quite a lot of concussion. And this is something that we also see within our clinic setting. So, what is concussion? So, this is taken from the NHS website, and it's just described as a temporary injury to the brain caused by a bump or a blow or a jolt to the head. Normally lasts up to a few days or weeks. And sometimes can involve emergency treatment, but the vast majority of people actually in reality get better very quickly, particularly if they're adults. The problem with concussion is the symptoms are hugely varied, and the classic one that I think we see the most of is a headache, and it's difficult trying to discern which is the headache from the actual head impact, if there was an impact, or if it's a headache from concussion. And I try to slightly, maybe oversimplify it and basically say, if you've hit your head here and you've got an egg on your head here and it hurts here, and that's your only symptom, it's probably not concussion, it's just where you've hit your head. But if you've hit your head here and you've got headaches anywhere else, then that's definitely going down the concussion route. You can also get nausea and vomiting. Sometimes you get amnesia, not always. Dizziness is a relatively common thing for particularly the children at rugby to talk about. Particularly that's normally within the first minute or so of the incident happening. They can get blurred vision, feeling just not right. And sometimes when you say that to people, like, yeah, it's just, I can't put my finger on it, but something isn't right. Confusion is obviously a relatively serious thing. And then they can also get neck pain, be sensitive to light, sensitive to noise, sad, anxious. I get a lot of crying children because they're just overly emotional. And when you see them in the weeks to come, you realize that they're not actually that emotional as a person. It was all the concussion that was just heightening their feelings. And then they can feel slow or just fatigued and wanting to just sleep all the time. So, mechanism for concussion, this is where there's often a little bit of confusion. Concussion doesn't have to be just from a blow to the head. I've certainly seen a hockey player who was dribbling along, got barged to the side. There was absolutely no contact to the head, but he was off sport for months and months and months. And it's that mechanism of basically your brain, which I describe to the kids as like jelly in a box, and you've just thrown that box around. And you also don't have to have been knocked out for you to get a concussion. So how do you diagnose it? And this is essentially a mixture of different ways, because there's no one particular test you can do that will diagnose it. So for me, the real key is getting the mechanism, how it happened, what happened immediately afterwards, and what their symptoms were. and also try and tease out what the symptoms were at the moment it happened, and then a little bit later, because it can change. And I get a lot of people saying, oh, I only had symptoms 5 minutes and then it had gone. But having those symptoms was still not a normal thing to experience. Examination is often relatively normal. But one thing that we do is a SCAT-5 examination. So SCAT-5 form, this is just a screenshot of the first page, is a concussion assessment tool. And you can find this online. If you literally type in SCAT-5 to Google, you'll get this that comes up. And it leads you through it. And it's an assessment of symptoms, of memory, of coordination, of balance. There's a little bit of mental agility in there, such as counting numbers back, recalling numbers backwards. And in an ideal world, you'd have a baseline SCAT on everybody to know what their normal function is. But the majority of patients that we see aren't elite and don't have baseline SCATs. So some of it is gut feeling. You kind of you know that most people should be able to get 4 numbers backwards, but if they're only able to get 3 numbers backwards, that just gives you a bit of an indication that something might not be right. But this is something that we use regularly to help with the assessment process for concussion. The question is then what do you do? So you've got a patient that you think is in front of you, think, right, I think they've got concussion. You now put them on what we call the graduated return to play, or GRTP. And this is a pathway that is designed to try and allow people to return back to physical activity, and be that sport, or even if it's just someone who rides a bike to work. The first phase is relatively straightforward, but the most frustrating. It involves complete rest from all physical activity. And for some people, that even involves being off screens, not using phones, not using tablets, because that can help trigger their symptoms. So we actually say complete and utter brain rest. Then over time, following a certain structure, you return them to sport, but the stages get more complex. So the RFU, for example, has a 6-stage return to sport. So stage 1 is that stage I was talking about, where it's complete and utter rest. And the length of that period, as I'll come on to describe later, is based on how much access you've got to a doctor and the length of and the age of that patient. Stage 2 is some light aerobic exercise. So a gym bike is perfect, not a road bike because you might fall off it, or going for a brisk walk if you haven't got access to any equipment. Stage 3 becomes a bit more sport specific. So it might be some sprinting or changing direction as sprinting. It's getting you doing something that's a bit more high intensity, but still in a safe environment. Then you move on to stage 4, which is non-contact training. So if you're a hockey player, for example, you do some passing and some skill drills, but no tackling. Same in rugby, throwing a ball around, catching a ball, but no contact. And then you've got stage 5, where you're in full contact. So if you're someone who's into sport, you do a full sports training session, no restrictions. And then if all goes well, you're signed off and you're back to sport. The key thing is that during the GRTP, from the start to the very finish, no additional activity should be done. So no going for a swim, no going for a bike ride. It's really important that they only do what the protocol says until they're signed off in the final stage. Now, as I talked earlier, the GRTP is something that's defined by your age and your access to doctors. So if you're an elite athlete, for example, so say you're a player at Harlequins, in fact, I've just noticed I've made a typo at the beginning, and I will edit these slides. So basically, if you are someone with regular doctor contact, so the bottom section, the first stage is 24 hours of complete, utter rest, so complete relaxation. Then stages 2 to 6, actually you can do on consecutive days. So you could do Monday, Tuesday, Wednesday, Thursday, Friday, for example. And the earliest you return to being back in a match is 7 days, playing properly. If you are someone with non-contact to a doctor, so say you're not an elite rugby player, you have to have 2 weeks complete rest. And then if you're deemed good enough to go on to the next stages, then you complete the next stages on sequential days with 24 hours in between, and it's 19 days to get you back. Children's a little bit different. So under 17 to under 19, who do have a baseline SCAT and a regular contact with a doctor. So these are your academy players, for example. they have a 7-day period of absolute rest, and then do stages 2 through to 6 with 24 hours in between. So it's very similar to the adult, except for their rest period is 7 days. Whereas anyone under 19 who doesn't have a doctor contact or a baseline scat has to have 2 weeks absolute rest. And then where this is key different for the kids, they have 48 hours between each stage going forward. So if they do stage 2 on a Monday, they do stage 3 on a Wednesday. Which means that kids, and this is the majority of children who get a concussion, are off sport for 23 days, which is, it's tough, but it's super important that they don't do the sport during that time. And I think that's really hard for both the child and the parent. So the risks, and this is what I talk a lot about to the kids of why they shouldn't be doing sport, is they're saying up to 50% in the literature percent chance of getting another injury if doing sport while concussed. And it's multifactorial, predominantly due to poor balance, poor decision making, fatigue, reduced coordination or concentration. And I think the difficulty is a lot of people towards the end of their concussion aren't necessarily aware that there's still problems, and you sometimes have to fight a little bit against them. And even earlier on, a lot of the kids, for example, will be like, oh, I feel fine, I'm absolutely fine. But actually, when you see them a few weeks later, they then realize that they didn't feel fine there, but now do. So they were almost convincing themselves that they're fine when they're not actually. So the big one that is the massive concern of concussion is if you do sport and get a second head injury, you can develop second impact syndrome. And this is essentially, if you get a second head injury, you can get cerebral swelling, brain herniation, and it can be fatal within minutes. And while it's incredibly rare, I actually know someone that it's happened to. So it's quite a significant consequence of concussion, that while being rare, is something that everyone needs to be really aware of. And I think if you've got a patient that's being difficult about sticking to the protocol, often kind of going through this and explaining it to them, they normally then kind of play ball a little bit better. So my take-home messages regarding concussion, essentially the rugby phrase of if in doubt, sit them out. So if you've got someone and you're umming and ahhing of whether they do or don't have concussion, if you're even having that thought process, take them away from the field of play. Don't let them do sport. The symptoms can be mild, really, really mild, lasting 5, 10, 15 minutes, or they can be really uncomfortable, and the kids or even adults can be off work for 6 months. So it's something that's not something to be ignored. You don't have to have a loss of consciousness in order to have concussion, and be really, really strict on the restriction of any additional physical activity other that's in their GRTP. And if you're unsure and if you're not happy managing a concussion, get them reviewed, because the quicker we can see them, the quicker we can get them onto the right pathways to getting them back into sport. So contact details will be shared out to everybody. But I think now we're going to move on to the Q&A section. So James, looking at it, I think you've got a couple of bone-related questions.
Yeah, so can you hear me all right? Okay, good stuff. So the first question we've got is, how does periosteal reaction due to trauma in X-rays show in an ultrasound scan? So I guess if we're talking about a periosteal reaction, what we're tending to see with ultrasound is we get the surface of the bone, the cortex of the bone, generally is very hyperechoic. So it's going to appear as white and reflects the ultrasound beam very, very clearly and very definitely. What we often see if there's a periosteal reaction is we see a little halo, so a little hypoechoic, a black halo, which sits just on top of the cortex, which suggests that there's been a bit of a periosteal reaction there. And that's often one of the softer, earlier signs that we'd be looking for with a bone stress injury on ultrasound. So although ultrasound can be very useful and can be very interesting in investigating these types of bone stress injuries, for me, I guess it's important to explain to patients that ultrasound would never be definitive for diagnosing a bone stress injury, because of course we can't see inside the bone. So we can't see if there is subtle bone stress injury. But generally we'd see that hypoechoic halo on top of the bone, We'd also see some subcutaneous edema, and you'd also potentially see some vascularity, which is indicative of a healing process going on in the periosteum. So that's the first question, hopefully answered. The second question is around bone injuries. So for someone with a very clear change in pattern, for example, during lockdown, they've started doing Joe Wicks. They have, without any other history or health concerns, their BMI is in the normal range, they're a non-smoker. So for all intents and purposes, they're a completely normal individual with no comorbidity who has purely increased their load. What are the thoughts on watchful waiting with reduction of load and training? Ultimately, I think that's a really sensible approach. In someone who is not high risk, i.e. someone with a normal BMI who has no other comorbidities, then I think watchful waiting is a reasonable approach, particularly if they don't have access to urgent imaging. So for sure, the best thing to assume is that they've got a stress fracture. Of course, you don't know, but you can assume that they've got a stress reaction or stress fracture. And how would we manage that? Obviously, you would offload. And again, that could be relative offloading. It could be reduction in overall training. It could be walking less, or it could even be obtaining an air cast boot and crutches. But ideally, what we want to do is get them pain-free. And ultimately, all our management is guided towards pain relief. And if they are in pain, then we're not offloading enough. So I think watchful waiting with reduction in load is a perfectly sensible approach. You could argue that for some stress fractures, so particularly anterior tibial stress fractures, that we've got to take them very, very seriously, and actually that we need to offload further than just a reduction in walking or reduction in training. However, that will probably come out in the wash anyway. If despite offloading, they're getting severe pain, are those individuals likely to be the ones that are going to go on to have further imaging? If necessary, I think on the NHS, I often get asked about how to manage these sort of injuries on the NHS. How do we get access to urgent imaging on the NHS if we're saying that an X-ray is normal, but we have a suspicion of a bone stress fracture or stress reaction? I would argue it's worth getting them sending them to your local fracture clinic, or having a word with the orthopedics team is probably the best way on the NHS to get them an urgent scan. So hopefully that answers that question. It's a very good question. The next question is, how common is the need for aspiration in your experience? So I guess we're talking about those big calf injuries where there is the large volume of interfascial fluid between gastroc and soleus. I must admit, I've probably done it 5 to 10 times in total in 6 years as a consultant. So very, very rare. That's not to say that we don't miss a lot of them. So that's something that's worth considering. And I do think that it is worth getting in early and trying to aspirate if possible. Obviously, that has to be done under ultrasound guidance. But I think, it's rare. But if you do see a big, tight, tense calf, and actually there's another question relating to this in a second, then worth getting early imaging. What I might do is let Natasha answer the 2 other questions on the Q&A, and then there are some questions in the chat as well. If that's all right, Natasha.
Yeah, absolutely. So the next question is, should we have a lower threshold of imaging in children and adolescents? No, I don't think we do. I think it's a case of, if a patient, if whether adult or child is not getting better, then you need to ask why. Is it something to do with the diagnosis, in which case, yes, imaging may well be required, or is it something to do with the rehab that they've been doing or not doing? Particularly with children, it's trying to engage them, make it exciting, making it interesting for them. And if the child is honest and says, well, actually, I haven't been doing my rehab, then actually we probably don't need to jump in and image them. I treat them very much as younger adults. And yes, they have different medical problems, but essentially they are still miniature humans. And I follow the same process in my head of whether I would image them or not. The next one talks about, in my practice, what percentage of unusual cases do I see or have seen, such as the ones that I've shared today. So I would see roughly 80 patients a week. I've been a consultant for 4 years now, and I've seen those 3 MSK cancers. So they are rare. But I was told, whether rightly or wrongly, that I should see probably 1 in my career, and I've seen 3 in what was a 3-year period. yes, they're rare. You just always have to keep that index of suspicion. And yeah, it's unlikely that they'll crop up, but it's just something you've got to be aware of. I've also got another question over in the chat, which talks again about the case I talked about earlier. Was the MRI of the lumbar pain chap routine? And would I always send these types of patients for an MRI? So he came to me, he self-referred. He hadn't seen his GP, he hadn't seen a therapist. And he, the only reason I MRI'd him was just something didn't feel quite right. And yes, he had some pain and extension. He had that positive stalk test. There was enough to make me think, yeah, we need to image you. But I certainly in my head wasn't thinking you're going to have cancer. So he was just a routine patient that was just a little bit different. Next one, someone has just asked, with the latter discussion about the red flags in the 34-year-old and 50-year-old, I'm curious about the gut feeling. What were the things you didn't like? Of course, there's evidence that we should trust this to a degree, but as part of an overall picture, yeah, I agree. The honest answer is I can't put my finger on it. I look back and I still think of those cases and think, what was it that made me scan them? I think with the second one, it was slightly an easier discussion with the 50-year-old lady who'd already been through rehab for her back to a certain degree and had already seen a very good lumbar spine physiotherapist and someone who I trust. And she came to me and said, she's not getting better and I don't know why. And I think that's probably why I scanned her, because she wasn't improving. The first guy was just something odd. And I can't express it any more than that. But I think with the second one, there was a bit more of an awareness that she'd already been trying to do rehab and wasn't improving. James, any of the others you want to jump in on?
There's a good ethical one for you. The one about the GP trainee. Do you want to read that one?
Let me see if I can find that.
You want to read it out?
Yeah, go for it.
So as a GP trainee with a specialist interest in sports medicine, I'd like to ask, can we contact the coach or teacher if we notice a young player is not taking the graduated return to play advice, despite the concussion I recently diagnosed in a GP setting, or should I leave that decision to the parents?
Oh, good question. I think it depends in what context it's happened. So if the child, for example, sustained a concussion during a match and the coach was there and is aware of the diagnosis and is fully aware of that they've been given this label of concussion, then actually I think the coach does need to be aware that, and I wouldn't necessarily kind of divulge the medical information to the coach, but I would talk to them about the return to play and the importance of adhering to it, so that, because if enough people are on board, then hopefully everyone will kind of jump in and help this child. I think also an important thing is to speak to the parents, because if you can explain it to the parents, then they ultimately should have control of their child. Often the parents are difficult and they want their child to be doing sport, and they get very frustrated that the child is off for 23, 24 days or even longer if they've had lots of symptoms. And I think that you just have to explain the consequences to the parents. And at the end of the day, the parents are responsible for that child. But coaches, etc., also need to be fully educated on concussion. I think that's really important.
There was a very good video that I saw on Twitter recently, which some of the audience might have seen, which was a hidden recording. I don't know if you saw this, Natasha, but it was a young girl. I think she was about 13 or 14. I believe she had got injured in netball or possibly in soccer and had a big injury. And she did a secret filming of the discussion with the coach, who basically said, by not playing, you're letting down the whole side, you're letting down the team. This is, ridiculous. We're going to have, this is going to have a big impact on the team. A really, horrible discussion and horrible points by the coach. And actually, it's, this has obviously gone viral and the coach has been sacked. But this is the sort of thing that young athletes are often exposed to, and often under huge pressure. And obviously, particularly in a school like the one that you work at, Natasha, there's a lot of competition for places, and there's also competition to enter the elite sports arena, and they feel under pressure with constant trials and not wanting to avoid or be out for any duration of time. So it could be a really, really tricky thing. I think treating and managing concussion in kids is pretty tricky generally.
Yeah, I think the other thing also to kind of be aware of is obviously not educating the staff, but if you educate the kid as well and say, well, actually, if you go out and play and you're concussed, you're not going to play to your optimum. You're potentially going to let your team down if they throw you the ball and you miss it, or you get another injury and there's no one to replace you. And actually saying you're not really helping the team. And if it's a kid that really cares about their team, then that can have a big impact. It's less beneficial if they're part of an individual sport, because it's more about them. But I think coach education, teacher education is huge, and I do lots of talks to the teachers and various schools about it. And we've seen the rates of children being concussed falling, and I think, and also their symptoms being less, and I think it's because they're being pulled off the pitch earlier when there is an element of concern, rather than putting them back on and just see how they get on.
Yeah, it's good to hear. Yeah. There is another question in the Q&A. So, Dr. Thing, this might be a stupid question. I'm sure it's not. But for calf injuries, when would you want to exclude a DVT? Yeah, it's a really good question. So, we normally talk about looking at the mechanism. So if someone has a very, very clear-cut mechanism of suddenly sprinting, feeling a pop in the calf, no pain prior to this, sudden onset pain, swelling, then the likelihood, of course, is that it's going to be a significant calf injury, and that is enough to explain the swelling. If they give enough, and we don't get such a clear history, and someone says, well, I played a game of football and might have tweaked my calf, but then a couple of days later I started to notice swelling and a bit of pain, then in an individual like that, for sure, I would consider getting imaging in your local sort of DVT pathway for sure. But obviously, when looking at a calf injury, I would do an ultrasound scan. I don't necessarily always look for a DVT, but if they've got a completely normal calf and they've got symptoms and signs compatible with the DVT, then I may well look for that as well. So good question. I think in the chat we've got a few questions. We're not going to be too much longer, I don't think. Let's have a look. So what is the management of massive calf injury like the one shown at 4 to 6 weeks down the line? Very, very good question. The answer is there's not much you can do about that area of consolidation or scarring in the interfascial plane. The likelihood is that it may cause recurrent issues going forwards. I guess the real answer to that is, from a medical point of view, is there anything we can do from aspirating, injection, operating? Probably very little. And it's probably more about really optimizing the rehab, making sure that the individual has seen a good rehab expert and specialist. Potentially with these people who are getting recurrent injuries, I would consider getting the involvement of a strength and conditioning coach. So often with physiotherapy, with osteopathy, if we use the analogy of elite sport, that those individuals, the rehab specialists would take the individual, the player, back to 95% of their full fitness. It would be S&C that would take them the final 5%. And it may be that individuals who have got these massive calf injuries that are still struggling for that last bit, they may well benefit from seeing someone like a strength and conditioning coach. So that's something to consider, but they are difficult to treat, and ideally we get them early. So that is that. There's one for you, Natasha. Have you answered this one? With the MRI of the lumbar spine, was the MRI of the lumbar spine chapel routine? Would you send patients with this type of presentation always for MRI?
So yeah, we've discussed that one. That was basically where there was a number of different factors that kind of led me to send him for an MRI. I think it wasn't an easy decision. It wasn't a clear-cut decision. The next question, however, we haven't answered was, how do you explain second impact syndrome and the risks to children without scaring them? It's difficult. I'm honest with them, essentially. I found that if I sugarcoat it too much, they generally think that concussion is a minor thing and don't take it seriously. we've actually started slightly changing the terminology and calling it concussion, but then also in the same discussion calling it a brain injury, because it became a bit of a blasé thing where everyone had concussion and it kind of, well, it was fine, it was a bit of a joke, and you got better from it. We reassure them, and obviously this is age dependent as well, like you don't go in and fully scare them if they're 7, but I'm honest and I explain what second impact syndrome is, because I think they've got a right to know about it. They also have an education session at the beginning of every rugby term which talks again about concussion, so they've already got some awareness of it, but in an age appropriate way I explain it, but I don't play it down either. I think that's really important. You don't make it too much of a minor issue.
Yeah. I think the last question that we've got is, how are sports medicine physicians and non-surgical orthopedics different? Well, I don't know that many non-surgical orthopedic consultants. I guess we would consider ourselves a sport and exercise medicine or musculoskeletal physician. So the way I explain it to patients is that we are medical by background, and that we try to avoid surgery as much as possible and to try to manage things conservatively. So we don't operate. We obviously have a big team of orthopedic surgeons at Welbeck, very experienced orthopods who we can refer to, but we don't operate, so we treat conservatively and we try to keep them away from the surgeons as much as possible.
Yeah, I completely agree. I mean, essentially we see a lot of the same patients, orthopedic surgeons and us, very similar patient case. I said, James and I, we try to avoid surgery if we can, but essentially if the patient needs surgery and it's the right thing to do, then we will lead them down that alley and assist them with it. But essentially the patients that walk through our doors, I think if we sat down and looked at what comes through and sees the knee surgeons at Welbeck and the knee patients that see us, very similar cases.
Yeah. Good. I think that is all of the chat and all of the questions as far as I can work out.
Yeah, it all looks good. I think unless anyone's got any other questions, I just want to say thank you very much for everyone for joining us this evening. As James said at the beginning, this will be available to view at the end of the week. And I believe there's some more webinars coming up, so feel free to join us. Thank you.
Thank you very much.